Right. Hi, everyone. My name is Julia Mayetta. We're so pleased that you could join us for this week's lecture in Volume 3 of our 12-week No Neuropsychology Didactic Series. This brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. And we would like to thank our sponsors for their financial support of this series. Before we start, we have some disclaimers. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions for today's lecturer can be presented through the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website later this week. Now it is my pleasure to introduce Dr. Christine Koterba for today's lecture on understanding pediatric brain injury. Dr. Koterba is a board-certified neuropsychologist at Nationwide Children's Hospital and a clinical assistant professor of pediatrics at The Ohio State University. She is the attending neuropsychologist on the Nationwide Children's Inpatient Rehabilitation Unit and is the associate track director for the internship in neuropsychology at Nationwide Children's Hospital. Her clinical interests include pediatric neuropsychology, traumatic and acquired brain injury, rehabilitation psychology, and spina bifida myelomeningiosis. Oh, I always mess that up. You get the point. Her research interests include psychological and neuropsychological outcomes in pediatric traumatic and acquired brain injury. She is a chair of the INS Brain Injury Special Interest Group, chair of the Education and Advocacy Committee of the International Pediatric Rehabilitation Collaborative, and is on the board of the Brain Injury Association of Ohio. So we are certainly excited to have Dr. Koterba today to present on pediatric brain injury. So I'll turn it over to her.
Thank you, Julia, for that wonderful introduction. It's funny listening to all the things that I'm involved in because I'm like, oh, that explains why I feel so busy. So I'm really excited to be joining you all today to be talking about pediatric brain injury. And before we get started, I want to show a video clip that just kind of shows a little bit about pediatric brain injury. And as I was looking for this, there's a lot out there on adult brain injury, not quite so much for pediatric brain injury. So I'm going to show you this clip that I found. And then if we have time at the end, there's another clip that I will share as well. So let's see here. All right.
I remember looking around and just there was not another soul there. I knew we needed to get to the hospital right now. I knew it was very, very serious, but I didn't realize exactly how serious it was. That morning it had rained just a little bit. Jess was out running errands. Our daughter, Morgan, it was her first season of soccer. So I had been wanting to get her out to the soccer field just to practice. Our son, Cameron, was playing goalie, and Ryan was out there just kind of walking around, playing a little bit, and then just picking grass, here and there. Morgan kicked the ball, and it went wide right of the soccer goal. I went to go retrieve it, and as I picked it up and I was turning around, and then there was the full-size, adult-size soccer goal was in mid-fall. I looked over to my right, and then there was Ryan laying there, his eyes wide open, and the dramatic, super pronounced swelling right across his forehead. I picked him up and I carried him maybe 3 or 4 steps, calling out his name, not getting any response at all. That's when I realized that he's not breathing. Luckily, my phone was in my pocket. I made the phone call real quick, let him know where we were at, sent help now. I had gotten CPR training a couple years before, and I tried to do my best. The first responders got there. Immediately, they were like, hey, we need to get a life flight in here. That's when I gave Jess a call.
I knew the situation was bad because before we hung up the phone, Andy said he didn't know if Ryan was going to make it. They took him to CT and quickly determined he needed to go into emergency surgery.
The impact had caused a portion of his skull bone to be pushed in, so it's putting a lot of pressure on his brain. And we removed those bone fragments and took the pressure off of his brain and were able to repair his skull that way.
Ryan was semi-comatose and he could maybe follow some very simple commands, but he really couldn't talk or walk or speak or do anything that a typical 3-year-old should do.
When you have a brain injury, such as Ryan did, a portion of the brain is injured, and that portion of the brain that's injured does not recover. Other parts of the brain that are not injured take over the functions that were lost. And this is where it's really important for patients to have good, high-quality rehab, which we do fortunately have here at Arkansas Children's Hospital.
We evaluated him to come to the rehab floor where he stayed with us for about a month, and he was able to eat and drink some by the time he left, but he still had the G-tube in. He was also able to talk some by the time he left. He was also starting to walk and to do some playful activities.
Jingle bell, jingle bell.
Singing songs and not completing the ending phrase to see if Ryan would pipe in.
You could almost see his wheels turning when Andrew would play those songs for him. And I do think it helped, not only with his speech, but just with his general cognitive progress.
I've had the privilege of following him since he's been discharged. He is back to normal. He is able to walk and talk and play and do everything now that a 5-year-old should be able to do. And he's done incredibly well after having this tragic accident.
All right. So you can kind of see that video that gives a little bit of an introduction to what it looks like when we see brain injury in kids. So now I'm going to pull up my presentation here. Okay, so I'm going to be talking about pediatric brain injury. And just kind of give an overview of what I'm going to be talking about today, I am going to start with just kind of understanding brain injury. So I'm going to go through some of the definitions and kind of epidemiology. I'm going to talk about primary and secondary injuries and TBI in children. So that's where we're going to start. Then I'm going to move to indicators of severity and acute recovery, and then longer term considerations. And in putting this presentation together, I'm sure that some people have a huge working knowledge of TBI and maybe have more of an understanding in adults or in children. And so what I'm hoping is that if you have that great working knowledge of TBI, this will enhance the knowledge you have. But if you don't have that, I really wanted this to be something that could stand alone and could provide a basic understanding of brain injury. So that is what my goal is for today. Now, we could spend hours talking about acquired brain injury and the effects of brain injury and prognosis and everything like that, and all the different types of brain injury. But unfortunately, we don't have that much time today. So I'm going to be just focusing on acquired brain injury due to trauma or traumatic brain injury. So a traumatic brain injury is a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head, or a penetrating head injury, like a gunshot wound. So what we can have with a traumatic brain injury is an open head injury where something penetrates the skull and the brain, like a bullet, or a closed head injury, which you can see here in this little video graphic, where the brain is moving around in the skull when the skull is coming in contact with a solid object. Now, the range can go from mild to severe, and what I want to really emphasize in this presentation is that traumatic brain injury, especially severe traumatic brain injury, is a chronic condition. Now, what was interesting in that video clip that I showed was that there were physicians and clinicians who had worked with that little guy, and they were saying, he's totally back to normal. He's doing everything that he should be. But what we could tell from those early days when he was in the hospital and then on the rehab unit, he had a very severe injury. And my guess is that while he's close to being a quote unquote normal 5-year-old, there's probably some deficits that are caused by the brain injury. And that's what we're going to talk about today. So as I said, TBI ranges from mild to like a concussion to moderate to severe. And what we're going to be talking about today are really the moderate to severe injuries with more focus on severe injuries. And when I put this little slide together here, I wanted this arrow to keep going because even when it comes to severe injuries, those are still on a continuum. And I'm going to explain a little bit more of that. You could have someone who technically has a severe injury and maybe they're on the lower end of the severity here, and then somebody who maybe is over here, they're going to look very different. The other thing that I want to emphasize as well, and I think that this is a pattern that we see in the field overall, is that people who work with moderate to severe TBIs are often different than the people who work with mild TBIs or concussion. And in my practice, I really almost see these as two different conditions. Even though they're on the same continuum, people with concussion present very, very differently than people with moderate or severe TBI. So this is what we're going to be talking about today. I'm not really going to be talking much about concussion. That is not my jam. I like the moderate to severe TBIs. So to give you some TBI facts, these stats come from a book that I'm going to reference a lot, and I'll include at the end, that I think is a really great book called The Source for TBI. 16 million children are treated in the emergency department with TBI. 600,000 children are admitted to the hospital with TBI. TBI is the #1 cause of death and disability in children, and males are about 1.5 times more likely to sustain a TBI than females. Now, I really like this slide, and it's a few years old here, and this data is really it's older than 10 years old. So things might have changed a little bit, but what we know is that the cause of TBI varies by age. Young children, here this 0 to 4 group, are much more likely to sustain a TBI by a fall than anything else because they're learning to walk. And then what we see is 15 to 24 and above are much more likely to sustain an injury in a motor vehicle or traffic collision, because what we see in these teenagers is they're learning how to drive. So that is a particularly risky time for driving, and the risk for accidents that cause head injuries is higher here. The two age groups at the highest risk for TBI are the young kids, 0 to 4, and then the 15 to 19-year-olds. And this is the group that we're going to be talking about today. So when you work with pediatrics, you see a huge range of causes of injury, and that can kind of change how people present as well. So I have been doing brain injury research and clinical work in brain injury for a long time, and it took me a while to really understand the mechanism and what happens, and then figure out a way to communicate this to families. So I am going to explain this in a way that I communicate it to families. So not a super jargony definition with lots of hard terms that are hard to understand, but a way that families can really understand what this means. So basically what ends up happening when you have a severe traumatic brain injury is you've got your skull, and I'm going to go into a little more detail about this in a few slides, but you've got your skull that's hard and bony. It has some sharp bony protrusions. And inside of that skull, as we all know, is your brain. Your brain is soft and squishy, and it's surrounded by fluid that normally just kind of absorbs shock and that sort of thing. So your brain isn't just like jiggling around in there. Now, most of the time this isn't an issue, but when we have a severe traumatic brain injury, basically what happens is the head travels at a high speed and comes into contact with something that's not moving. So if you can imagine being in a motor vehicle collision, traveling at a high speed, crashing into another car or a tree or something like that, your head goes forward and hits the dashboard, and then it goes backward after that. So we've got these different forces working on it. When your head goes forward, your brain actually hits the back of the skull, as you can see here. And then when your brain goes backwards, your brain hits the front of the skull. So it's a little bit counterintuitive, but basically your brain is moving at a very high speed, and that is the important thing to understand here. As a result of that, we see different types of injuries. So we see primary injuries that arise directly from the injury. So these could be things like a skull fracture, bruising, bleeding, or diffuse axonal injury. And then we see this secondary injury, and these arise almost as a result that's more indirect from the injury. So things like swelling, increased pressure, hypoxia, ischemia, and hematomas. Now there's also a neurochemical cascade that happens where there's a lot of neurotransmitters that get released that can also lead to further injury. And then down the road, when we do updated neuroimaging, we might see things like volume loss, atrophy, degeneration of white matter regions, and things like that. We can also see things like hydrocephalus or seizures that happen maybe days or weeks after more severe injuries, although that's not as common as some of these other things. So these primary injuries happen kind of regardless. This is what the traumatic brain injury causes. The secondary injuries, though, are things that the medical teams are working really, really hard to avoid. So we know that we've got this primary injury. Now, what do we do so that we don't have as much of an effect of the secondary injuries? And that's why it's really important that when someone experiences a severe TBI, they go to a level 1 trauma center where they can be managed by people who know what to do to keep a lot of these secondary injuries from happening. So this, I hate it when people say this, but I'm going to say it anyway. There's a lot of detail on this slide, but this really just goes through what the brain damage from the TBI is. Basically, when you have this brain and moving around inside the skull, there's going to be impact on the skull. Like I said, I'm going to talk a little bit more about that. Then we also see some tearing of tissues, that shear injury from just these physical forces acting on the brain, could be bleeding, increased pressure, as I mentioned, seizures. Sometimes what can happen is some herniation of the brain, hypoxic injury if there's respiratory arrest, so if there's damage to the brainstem. And really what this ends up causing, in addition to all these other things, is this microscopic damage to the cells and their connections, which is really, really important and makes severe traumatic brain injury different from other types of acquired brain injury. So when we see a severe traumatic brain injury, sometimes we see focal injuries in addition to kind of everything else that I was talking about. And I'm going to show this slide here. So as I mentioned before, we've got our brain inside of a sharp and bony skull. And there are bony protrusions here in the front and then on the sides here. And so what can happen when you've got this soft, squishy brain traveling at a high speed inside of this sharp, bony skull is it can collide with these bony protrusions. And so when we see focal areas of bleeding or bruising, oftentimes it's going to be in the frontal lobes and the anterior temporal lobes, because that's where these bony protrusions are. We don't always see that, but oftentimes if we're going to see focal injury, it's going to be in those areas because that's where those bony protrusions are. Now, again, what makes severe traumatic brain injury different than other types of acquired brain injury is that there's a combination of these focal injuries here and then diffuse axonal injury, which happens throughout the brain. And this is microscopic damage to the axons. What happens here is that these axons between the neurons, they stretch and they strain, and in some cases they break, and you can see what happens there. It's typically diffuse, so it means it happens throughout the brain and happens in both hemispheres of the brain. But it tends to happen more at the boundaries between the gray and the white matter. And so what's interesting, if you think about gray matter and white matter, they are made up of different cell densities. And so basically what that means is when the brain, going back here, is traveling really fast inside the skull, we have the gray matter and the white matter that are traveling at different speeds because they have different volumes of cells and different types of cells, or different volumes of myelin, that sort of thing. So because of that, what ends up happening is we see this axonal injury because the gray matter and white matter travel at different speeds. So those axons that go between them end up stretching and straining and breaking. And these are some areas where we might tend to see more of this diffuse axonal injury, although it does tend to happen throughout the brain. So basal ganglia, periventricular regions, the cerebellar peduncles, the fornices, corpus callosum, and then fiber tracts of the brainstem. Like everything that we're going to talk about, and intuitively this makes sense, the more diffuse axonal injury we see, the more focal injuries we see, those are associated with worse outcomes. And we're going to talk some more about that as well. So I really liked thinking about diffuse injury as cutting down trees in a forest. So if you have mild diffuse injury, which oftentimes we're still going to see that with severe brain injury, but maybe not, the most severe injury that we're going to see, it's like thinning a forest. So someone might notice some gaps in their brain functioning where certain cell branches were, but over several months, the cells are going to grow some dendrites and they overcome that disruption. What was interesting is there was a physician in that video that I showed that said something like brains do not recover, or this does not change, or something like, the damaged part of the brain doesn't recover. And I think that we have evidence that shows that it actually can recover in some ways, but might not recover enough to make up for the damage. And that's what we see with a severe diffuse injury. It's almost like going and just clear cutting part of the forest. So not just wiping out a few trees here and there, but maybe wiping out a whole big area of the forest. And this leads to permanent gaps in brain functioning because these cells cannot overcome that loss. And so if we have someone who has a severe diffuse axonal injury, we're going to see worse outcomes over time. Now, one thing, like I said, obviously this is a talk on TBI in children, so I want to try to kind of weave developmental considerations throughout this. And you're going to hear me say this a couple of times. What we know about kids is that their brains are developing. So they respond differently to brain injury than adults. And there's two kind of theories that we have. We have the plasticity theory, which says Well, if the brain isn't fully developed yet, then there's opportunities for reorganization. So that should be a good thing. Kids should recover better. And we know that from things like stroke, for instance, if you have a child who has a stroke in utero or before they're born, their outcomes are going to be very different than an adult who had the same stroke because their brain is still developing. However, there also is this early vulnerability hypothesis. And what this basically says is that yes, the brain is plastic, yes, it can reorganize, but you're disrupting normal development. And so what happens is a child who is on a typical development trajectory, when they have this injury, that is really disrupting those building blocks to developing later skills. And also what research suggests is that outcomes are worse in younger children, and the full impact of brain injury may not appear until later when new skills are developing. So again, thinking back to that 3-year-old, we saw the video of him at the beginning. He had the brain injury when he was 3. He recovered, made lots of gains, acting like a typical 5-year-old. Well, 5-year-olds don't need to do things like make complex decisions. They don't need to solve complex problems. They are kind of disinhibited and inattentive to begin with just because of their age. What's going to happen to him as he gets older and those executive functions and attention functions are supposed to be coming online, but they might not be because of this early injury. So again, brain injury is a chronic condition. And in children, they've got their whole lives ahead of them. So we want to always be remembering that they had this injury, no matter what age it was at, because that can really impact their overall development. So we talked about understanding brain injury and kind of gave you a basic rundown of that. Next, we're going to talk about indicators of severity and acute recovery. So I'm going to talk about severity, assessing recovery, and then what a typical recovery course looks like. And then we're going to finish with longer term considerations. And I don't call this long-term considerations. That kind of grouped everything together after the acute period. So there's a lot of different indicators of severity that we can use. Glasgow Coma Scale, or GCS, is the most common one. This is something that is typically done at the scene or in the field where the injury happened. It's done again when a child gets to the emergency department, and then, excuse me, and then it's frequently done throughout their acute hospital admission, so in the ICU. It is a measure of child's neurological status at a point in time. So it's almost like the physician comes in, takes a quick picture of them, and then leaves. That is what the GCS is. If they were having a tough time at that moment, their GCS score might be lower. Now, these predictors of outcome, or these indicators of severity, are better predictors of outcome because they reflect the rate of recovery rather than just a snapshot of a child's functioning. So post-traumatic amnesia, loss of consciousness or duration of coma, and then time to follow commands. And those are things that we're going to talk about in a little bit more detail. And then there's some medical indicators as well. So I have a couple different tables in here that go through severity and how to determine severity. Again, if you think of that continuum I showed before, we have mild, moderate to severe. And basically for all of these things, the time of loss of consciousness, the longer it is, the more severe the injury is, the longer post-traumatic amnesia is, same thing. And what you can see with GCS is that higher scores indicate a more mild injury and lower scores indicate a more severe injury. So again, a couple different tables here that go through the same information. First, we're going to talk about loss of consciousness. I'll back up here. Mild might just be a few minutes, moderate, 1 to 24 hours. And severe is going to be greater than 24 hours.
Dr. Koterba, I'm so sorry to interrupt. We're getting a couple of messages just about your audio. Yeah, maybe sometimes scooting closer helps, or headphones, but probably scooting closer will work.
Okay, is this better?
Sounds a little bit better to me.
Okay, sorry about
Thank
that.
you.
Yeah, feel free to cut in and interrupt if there's any more issues. I can talk louder too.
Okay, thank you. Sorry.
No problem. Okay. So when it comes to here, this loss of consciousness, sometimes what we can see after severe traumatic brain injury is that patients can have a disruption in their arousal and awareness. And this can last for days, weeks, especially with the most severe of traumatic brain injuries. We might see this. It's fairly rare, but it's still something to be aware of. So when patients experience the disorders of consciousness, they go through this progression, although they might stop at any one of these points. So a coma here is where someone's completely asleep. They have deficient arousal and awareness, and they typically are sleeping the whole time. This may be medically induced or it may be related to the injury. Next, what we see is patients will go through an unresponsive wakefulness state when they might be awake, but they're not really aware of what's happening. And their sleep-wake cycle might be intact. So they might be awake during the day and asleep at night, but still we're seeing that even though they're awake, they're not really aware of what's happening around them. Next, patients can go through a stage that's called minimally conscious. And this is when they are awake, but they might not be fully aware yet, although their awareness is starting to improve. And then what we see is also sleep-wake may be intact, although patients in these two stages may still be sleeping at weird times of the day and then awake at night. And then hopefully patients will progress to the state of post-traumatic amnesia when they're conscious, they're awake, they're aware of what's happening, but they still might be very confused and have trouble with new memories. So next I'm going to talk about the GCS score and why this can be a little bit tricky with kids. So this is based on eye-opening, motor response, and verbal response. And again, thinking back to this 3-year-old who was injured, the higher levels of this motor response and verbal response, they need to be able to obey a command, which some young kids are not going to be able to do. And their verbal responses, they must be able to respond to questions. They have to have normal orientation. Their speech needs to be intelligible. So this is going to be really hard for younger kids, although this is what is kind of the go-to measure of severity, especially in the field. So when you see a GCS score in a child, it's important to think about how old they are and where they are developmentally. Could they do these things before the injury? So next I'm going to talk a little bit about time to follow commands. Again, the longer it takes a patient to start following commands, the more severe their injury is. What I like about time to follow commands is it's really easy to assess. What we're looking for is that a patient follows 2 commands within 24 hours. This could be things like open your mouth, lift your hand, say your name. What's important is that we don't want to use things that they're already doing. So maybe they're opening their mouth a lot spontaneously, and it's going to be hard to tell if they're following a command or they're just doing it on their own. Or maybe you put your hand in their hand. Parents do this all the time and say, squeeze my hand. But that's kind of stimulus bound because it's really common when you put something in someone's hand, they're going to squeeze it. Time to follow commands also is a great predictor for outcome. There have been a couple of studies that have looked at this, and one that showed that patients who took longer than 26 days had worse outcomes on a functional measure after injury. Then finally, we're going to talk about post-traumatic amnesia. And this really describes changes in mental status when a child's disoriented, they're confused, and they aren't laying down new memories. There are a lot of different measures that we can use that look at orientation. And a child is considered out of PTA when they're following, or they get high enough scores on these measures. But what's tricky again with kids is developmentally, they might not have been fully oriented before the injury. You know, if you have a younger child, they might not know what day or time it is. And really what we're looking at is that orientation and awareness. So I included this on the Rancho levels because again, I think that this is a helpful way to think about one's progression through recovery from traumatic brain injury. So typically what we see in the severest of injuries is that at a level 1, there's no response. So that would be when a patient's in a coma. As they are recovering, their responses are becoming more localized, more consistent with where they should be, but patients often pass through this phase of confusion and agitation, which is really, really common after brain injury. If we go back to this post-traumatic amnesia here, patients are disoriented and confused and they can't remember things. So if you could imagine, you know, sometimes this will happen to me when I'm traveling. I'll wake up in the morning and I'll have this moment of kind of, where am I? And then I remember where I am. I'm in a new bed or maybe in a hotel. Well, I imagine that this happens all the time to patients with severe traumatic brain injury when they're in the hospital. So they wake up and they're looking around thinking, where am I? Who are these people? And that's scary. That's confusing. So it's no wonder that we see some of this agitation here as patients are recovering. So with severe brain injury, what we often see, just like you saw in that video, patients will go to the emergency department, they will get medically stabilized in the intensive care unit. Hopefully they end up coming to rehab where they'll further recover. And then we're working on getting them back into the community and getting them discharged from the hospital. When it comes to assessing recovery, it's really important to understand how people recover from brain injury. So it's common to see physical, cognitive, and then emotional, social, and behavioral difficulties after brain injury. The most recovery occurs in the first 3 to 6 months. So on this little graph down here, this is where we're going to see the most recovery. And then this is going to continue at a much slower rate over time. So typically what we see is every day when a patient's on rehab, they're making gains, things are changing, they're improving constantly. But once they go home, and then once we're several months out or several years out, there might be some improvement, but it's going to be much slower over time. We typically see the physical improves first, then we see some improvement in cognitive impairments, but oftentimes it's the emotional, social, and behavioral deficits that can last the longest and be the most persistent. And just because I'm saying that the physical and the cognitive improve, it doesn't mean that it fully improves. We often are going to see persistent difficulties. These tables go through some physical, cognitive, and emotional impairments. And then here's one that is similar. And I think people have access to these. Again, this is included in the source for TBI book. And there's some really great resources in here. Is everything still okay with the audio? Okay, I didn't hear anything, so I'll continue on. All right, so we talked about understanding brain injury, indicators of severity and acute recovery, and then longer term considerations is what we're going to talk about last. So longer term outcomes, predictors, and the role of neuropsychology. So again, just to go back to this graph here, we see the most recovery here in this first 3 to 6 months, and it's going to slow down over time. That doesn't mean it's going to completely stop. It's going to really be different for everyone. And we're going to talk about some of the predictors that are going to influence recovery. But again, moderate and severe TBI, especially severe TBI, represent a chronic condition for children and families. So I included a lot of outcomes here that I'll kind of go through a little bit quickly and just kind of hit on the highlights. So when it comes to intellectual functioning or IQ, we typically will see a decline in a child's IQ test performance. We see greater declines in nonverbal IQ, which represents more fluid processing, than in verbal IQ, which represents more acquired knowledge. We tend to see that these improve over time, but the post-injury IQs are still lower than pre-injury estimates. In language skills, expressive language deficits are very common. We'll see difficulties with things like comprehension, confrontation naming, object description, verbal fluency, and really significant impairments in pragmatic language and discourse. And just like I was talking about on these previous slides here with some of these emotional impairments, you can imagine if you're having social difficulties because your communication skills aren't as good, your discourse isn't as good, that's going to lead to some of these emotional impairments as well. So it's all connected. In terms of nonverbal skills, we can see impairments here too that might be influenced by motor impairments. So if you have difficulties with motor coordination or motor slowing or fine motor skills, that's going to impact things like drawing or block design. And then memory deficits are very common. So as I said, we have those bony protrusions right by our temporal lobes. We can see focal injuries there that can impact memory. Difficulties on verbal memory tests have been documented. Fewer studies of nonverbal memory, but that is likely impaired as well. And then implicit memory, so learning how to do things, might be better than explicit memory, so remembering facts and that kind of thing. Again, something to stress here is that with younger children, we might not expect them to have very strong memory skills yet at the time of their injury. So we kind of have to wait to see how their memory is going to look like over time. We might not really realize the full impact of that early injury on their long-term functioning. Attention problems and executive functioning problems are also very common. Again, not only do we have the risk for focal injuries in the frontal lobes, but there's also so many connections between the frontal lobes and other parts of the brain that can really be impacted by that diffuse axonal injury. So I kind of think about whenever I see that someone has had a severe brain injury and they've had that diffuse axonal injury, I'm expecting that they're going to have some attention problems and executive functioning problems. But again, looking at these deficits in planning, verbal fluency, concept formation, mental flexibility, you wouldn't expect a 5, 6, 7, 8-year-old to be very good at this. It might not be until someone's teenage years that we start to see these deficits emerging. Motor skills, deficits in fine motor speed and dexterity are also very common. And then in academic skills, what's interesting is that declines in academic performance are very common. So you could have a child who's maybe in middle school, they've always gotten A's and B's, they have a severe traumatic brain injury, they go back to school, now all of a sudden they're getting D's and F's. But that's not necessarily because their reading and their math and their writing skills have declined. Oftentimes, kids after brain injury actually do pretty well on standardized academic testing and the types of testing that schools are doing. They do okay on those. Where they're struggling more is with the things where they need good, strong executive functions. So getting their homework done, getting it turned in. There may also be some behavioral changes that start to impact their academic functioning. Adaptive functioning problems are very common, oftentimes related to factors other than injury severity. And we're going to talk a little bit more about those. Very similar to what we see with emotional and behavioral functioning. Some studies suggest depression, attention problems, behavior problems are all more common after more severe injuries. And the predictors for emotional functioning and adaptive functioning are things like the pre-injury behavior functioning, injury severity, of course, pre-injury intellectual functioning. So where was the child before in terms of their IQ, their emotional behavioral functioning? What's the family's status like? What is their socioeconomic status? What is the family's psychiatric history and just global family functioning? So this is really important, especially when you are thinking about a child, because if you have an adult with TBI, they might be going back to live with their spouse. It might be that they're moving back in with older parents, but with a child, it's all about the family. And it's really, really important that the family is functioning at their best to help their child recover. Interestingly, behavioral functioning after the injury does not seem to be closely related to cognitive outcomes. Cognitive outcomes are more closely related to injury variables, whereas behavioral outcomes are more related to the pre-injury variables like family functioning. So now to talk a little bit about predictors of recovery. So injury characteristics, this is a big one. Obviously, the injury severity, just like we talked about, the more severe the injury, the worse the outcomes are likely going to be. And we use these predictors for outcome, just like we were talking about for assessing severity. But there's also medical indicators. So these are things like brainstem abnormalities, seizures, increased pressure, other types of secondary injuries that we see. All of those are going to increase the risk for more adverse outcomes. Focal brain lesions are associated with outcomes over and above diffuse insults. But really what we see again is kind of an effect of both the focal injuries as well as the diffuse axonal injury. Now, what I think is so cool about working with kids is that the environment plays a huge role in terms of their cognitive and behavioral outcomes. And that gives us a chance for possible intervention. If we can fix the environment a child is going into, then possibly we can improve their functioning. Now, that's a tall order and something that I think a lot of people are spending energy on is really addressing what's going on at home and the family functioning. So all of these factors are things that can influence a child's recovery. And then we know that the developmental variation too, like I had mentioned, the age of injury, the time since their injury when they're being assessed, and then the age at assessment. Younger children tend to have worse outcomes than older children. So again, kind of returning to this thought, immature brains have this greater potential for recovery because of the plasticity and opportunity for reorganization. And so young brains can change, they can compensate to an extent, but early injuries also disrupt ongoing development. So what we end up seeing oftentimes is that young children grow into their deficits as higher order skills are expected to develop. And where I see this becoming a big problem is when we have a child maybe who's 1 or 2 and they experience non-accidental trauma. So they sustain a brain injury because of abuse. A lot of times those kids are placed into foster care and maybe adopted by another family, or they're living with extended family. And so it may be that their new family has lost sight of this earlier injury. And it's really important that we conceptualize brain injury as a chronic condition, especially with kids, because they're going through development. We're expecting them to change. We're expecting them to develop new skills, but this injury could really disrupt that. So as a neuropsychologist, I think that we are uniquely positioned to work with children with a history of TBI. And we have several roles: clinician, obviously, educator, advocate, and a family resource. And I feel like in the work that I do with pediatric TBI, I am all of these roles at kind of different levels depending on the needs of the family. So some of the things that I do is monitor recovery over time. So I'm going to include a little bit of information about the different ways that I do this. I provide psychoeducation and then help with school, home, and community reintegration. So again, you can see how those responsibilities really fall under some of these different roles. So one of the measures that I use is called the cognitive and linguistic scale. And this is a way of quantifying recovery and change over time. This is not a typical neuropsychological measure that has been normed and standardized, but instead what we're doing is we're comparing a child's performance to their previous performance. So we do this each week or every 2 weeks, and then we look to see how are they changing, how are they recovering over time. So this can really serially track recovery. And there are strong correlations between this and another functional measure that is used in pediatric rehab. So at Nationwide Children's Hospital, I have worked with a couple of my colleagues and fellows to develop an education program that is used with parents and families of children with brain injury. And we call it BRAIN. And it's a module-based program to provide brain injury education. So just like I mentioned earlier on, the main goal of a child's medical team when they're in the emergency department or they're in the ICU is really to keep that child alive, prevent those secondary injuries, try to set that child up for success if at all possible. So that is what they're really focusing on. That's their expertise. That's their time, their energy, their attention. And in the hospital, for anyone who's been in the hospital or had a child in the hospital or who's worked a lot in a hospital, when physicians round, they come by for about 5 to 10 minutes. They check the child, they try to answer questions, and then they've got to get to the next patient. They might have afternoon clinic. They might be going to surgery. So they have got to move pretty quickly. They don't have time to sit down with the family, really explain the injury and what it's going to mean for this child's prognosis. And what I think is so cool about that video that I showed you earlier is you could see how severely that child was injured, how involved that hospital admission was. And really, although, like I said, he probably has some difficulties related to the injury, he's doing really, really well now. And as neuropsychologists, we have that kind of wide angle lens on recovery. And so we're able to share that information with families. We also have a little bit more time than, say, a neurosurgeon who might be running around trying to get a bunch of really time-sensitive stuff done. So this is a way that we provide systematic education to caregivers about the brain injury, recovery, and how to prepare for outcomes. Like I said before, one of the things that we know is that family functioning, caregiver functioning, family environment, all of those things can influence a child's recovery. And all of those things are things that could be changed. So it's something really important. That's a way that we could potentially intervene. I think it's also a way to give families some hope. They can't change the severity of their child's injury. They can't change whether their child had focal injuries or had to have surgery, but they can capitalize on any great strengths that they have in the environment and the home system. All right, so again, things that we talk about and that I think is really important to talk about with all families of children with brain injury is what recovery is going to look like, what the changes are going to be like, how we get this child back into school, how we make sure they're safe, and how we can encourage caregivers to take care of themselves. We also complete discharge testing. So this is just a really brief evaluation to look at a child's strengths and weaknesses. And what we want is for the child to be functioning fairly well, medically stable, so that we can work with the team to get them back into school. Something that's really important to remember as well is that patients are often discharged when they're walking and able to complete activities of daily living. So again, referencing that video you saw in the beginning, they said when he left the hospital, he was starting to walk, he was starting to talk, but he still had a wide way to go. And that is what we see when patients are leaving the hospital. So we want to get a snapshot of where they are, but we also recognize that some of their deficits might be hidden, and it might take for the family to get home, get out of the structure of the hospital to really start to realize some of those things. In terms of long-term management, when it comes to severe TBI, I think it's really important as clinicians for us to have an understanding of what those initial days and weeks look like for the patient and the family. What I have heard a lot from families is that when they get that phone call that their child has been in an accident, or they get the call to come to the hospital, it's like time stands still. Then they get there and it's just this whirlwind of a lot of different information coming at them, a lot of things happening with the main goal of keeping the child alive. If we don't have that understanding as clinicians, it's hard for us to have that full understanding of a patient or a child and their family and what their journey has been like. And it's important, again, to view TBI as a chronic condition. Oftentimes with severe TBI, we're going to see long-term difficulties or deficits, but they might be very subtle. And it might take having our background in neuropsychology to really pick up on those. And again, they might not appear until they're developmentally appropriate. So when you're working with children of any age who've had a brain injury, it's important to talk about how things might look in the future and think about what are the time points that I want to be seeing this child back again. If they're in fourth grade and they're doing pretty well, we might want to see them back in middle school because that's going to be a bigger load on executive functions and more demands for independence. And then we might want to see them in high school as they're getting ready to graduate and kind of make that transition to adulthood. All right, another thing too to think about is when we're working with children, we want to make sure we're considering school and what that's going to look like. So a lot of times people might qualify for an individualized education program or a 504 plan. They might qualify for financial resources depending on what they're getting through their family, how severely they're injured. And then there's a lot of community resources as well. Oops. I also included some of my favorite professional resources. Brain Injury Association of America is great, and there's a lot of state chapters. And I will say, if you're a trainee, if you're early career, and you're involved in brain injury work, I highly recommend getting involved with your local state chapter of the Brain Injury Association. I've been involved with our Brain Injury Association of Ohio, and it's really been a great way for me to connect with other professionals and also to kind of advocate for the children that I work with, because there's a lot of focus in the world of brain injury on adults and not as much on pediatrics. So I think it's a great way to network. I think it's a great experience to have. And it really is a way to get involved with community advocacy. The Source for TBI is a really excellent book that was written by a neuropsychologist and a speech therapist. And it also includes a brief measure of cognitive functioning there as well. Colorado Kids Brain Injury Resource Network is excellent. And then here are a couple other resources that are really good. So I am going to stop sharing so that we can go ahead and open it up for questions.
Thank you so much, Dr. Koterba. That was really wonderful. I think it's a really good in-depth review of pediatric brain injury. So we did get a few questions that we'll want to start out with in the chat. So the first one has to do with determining change from prior functioning. So this question says, how do you determine change from prior function or premorbid functioning for a child? And how does this impact your diagnosis?
Yeah, so I think that's one of the things that is really different about working with kids than it is with adults. Because with adults, you might have more evidence of what their prior functioning was, what type of job they had, how they did in school, and that kind of thing. So there's a few things that I look at. The parents' education level and occupation is a huge thing that I always am asking about, no matter what kind of work I'm doing, because that gives me a sense of where I would expect the child to be. Now, that's not a perfect indicator, but they are highly correlated. So that's kind of the first thing that I'm going to look at. And that's going to tell me, okay, I have kind of an idea of where I could expect this child to be in terms of pre-injury functioning. And then other things would be looking at school. I try to get school records from our school liaison as quickly as possible so that I can see, did they have an IEP? Have they had testing done? What kind of grades were they getting? How did they do on state standardized testing? And another thing that we can use as well is just looking at some of those more crystallized intelligence skills, things like word reading can be a good indicator of pre-injury functioning. Although if a child has a severe enough injury, that's not going to be as sensitive. And so really it's just kind of pulling together all these different pieces of information and doing a very thorough interview. Were developmental milestones met on time? Were there any other things that complicated development before the injury? You know, kind of pulling all of these pieces together.
Yeah, that certainly makes sense, integrating everything.
Mm-hmm.
The next question is about whether there is a general cutoff kind of where children who sustain moderate to severe TBI have better outcomes. So this person is particularly interested in kind of vulnerable periods. So whether that's over or under the age of 3 or 5 or kind of where that sits.
So I think the thing that's been so hard is that there have been a lot of studies that have looked at age and kind of developmental stages, and it's been really hard to come up with like those clear cut points. And I've seen, I think this is more in stroke, so other types of acquired brain injury, where there can also almost be like a U-shaped, kind of projection of recovery. So maybe children who are the youngest and children who are a little bit older tend to do better or worse. And so I think it kind of depends on what you're looking at. I think that what is, again, very complicated is with younger children, there might be that potential for reorganization and plasticity, but it is a huge disruption to development. I think the other thing too is the more resources that a family has, the more kind of stability they have in the home is such a huge predictor of outcome that I think that kind of goes above and beyond that age and injury. Because I've seen some kids who have very severe injuries, but it's like one of the parents was able to take the year off work and they could prioritize therapies. And I had a parent who I worked with who hired occupational therapy students, and he would have them come in and then rotate them out as they were graduating the program to work with his daughter. And so, like things like that, that's going to help a child to do much better no matter what age they are, versus somebody who just doesn't have those resources. They're not going to have those same advantages. So it's not really answering the question exactly, but hopefully that helps.
Yeah, I think that's an important point, and we're definitely going to be talking about health disparities a lot more in this volume of our series. So I'm glad that you brought that up because it's certainly important.
Yeah, definitely.
The next question is about the presence or absence of loss of consciousness. And this person says they've read that it might not actually be an indicator of TBI severity, but is there any mixed research on that, or how does that kind of play into the clinical picture?
So when I think about assessing severity, I think that really we have to use multiple indicators, and using just one indicator is really not going to be sufficient. I've seen some kids where, because they had such extensive orthopedic injuries, that impaired their kind of level of consciousness and awareness. So they had a lower score on the GCS, but it really was not indicative of the severity of their brain injury. And so I think that is sometimes how those things can get kind of mixed. If somebody comes into the hospital in a coma due to their injury, and they've had that extended loss of consciousness, or maybe duration of coma is what we'd be looking at that point, that's definitely going to indicate the severity. But I think that just like GCS, it might not be quite as sensitive, and it probably is going to depend more on kind of how that is being assessed. I think another issue too is with some of those indicators that are based on kind of the report from the first responders, it's not always the most accurate information, because that's not really what their number one priority is. Again, those people that are working with patients right in the beginning, their number one priority is keeping them alive, getting them the help that they need. And so I would think it's kind of more like related to those types of things, if that makes sense.
Definitely. And that's actually a good segue into our next question related to coma. So this person asked kind of, how do you differentiate between duration of unconsciousness, which is injury related, versus that which might be medication or sedation related?
Yeah, that's a really good question. And that's one that I had asked one of my mentors at one point, because that was something that was hard for me to understand too. And the way that I kind of think about that is basically, if you have an injury that is so severe that you need to be medically sedated, that is an indicator of severity. So at that point, we're not really trying to decide, well, are they in a coma because they're just in a coma? Are they in a coma because they're medically sedated? But again, we're looking at that whole time as being like a duration of coma, or maybe it takes them 15 days to follow commands, but they were medically sedated for 14 of those days. So I think, again, we're going to be looking at, okay, well, when was that sedation lifted? When did they start following commands at that point? And I think what is hard, again, and with all this that we're talking about, is there's no one single perfect indicator. There's no one single perfect answer. It's really kind of looking at the whole big picture and what a child's rate of recovery looks like versus, just kind of one indicator maybe.
Yeah, definitely, because of all the heterogeneity and making sure you integrate everything.
Yeah.
That's
And when you have somebody who has really complex orthopedic injuries, that is going to make things harder too, because then you're teasing apart, okay, what's related to the head injury versus what's related to this other trauma that they've experienced. And I've seen kids before where looking at kind of the initial notes of where they were at the scene is very different than kind of how they progressed in their recovery. It was different than what I would have expected.
Definitely. I think this next question is related actually to the kind of faster recovery during that first 3 to 6 months post-injury. So in your experience or based on the research, is this usually more related to rehabilitation or kind of the natural course of recovery?
So I think of it as kind of both. First of all, I see that as kind of a critical time period of a lot of recovery. So there's this opportunity for recovery, but we have to capitalize on that opportunity by providing comprehensive rehab services. So one thing that has been interesting to me in the work that I have done with families, and the more I've gotten involved in family education, is I've heard from parents who've said, especially parents who are at more rural hospitals, they're in the emergency department and a physician says, you need to start, or in the ICU rather, and the physician says, you start looking for a long-term care facility for your child or start looking for a nursing home. And when I hear that, I'm just like, that is not what we want to be doing here, because we don't know what that child's recovery is going to look like. We have these prognostic indicators, we have ways of assessing the rate of recovery, but we know that the most recovery can happen early on. And so we want to capitalize on that. And so we want to do everything that we possibly can to try to get them to come to rehab. And there's some people where no amount of rehab is going to change their recovery, and they're not going to make the gains that we would want, and they're not going to recover the way we want them to. But for a lot of people, I feel that we just have to give them that chance, and we have to keep that hope that there could be, recovery is unpredictable, and especially in kids. And so let's do everything we can to get them medically stable enough to come to rehab to see if we can, kind of push up their recovery a little bit more.
Right. We have time for one more question. So this one is kind of putting this in the context of the full spectrum of traumatic brain injury. So how soon would you recommend that children return to regular activities, obviously after hospital discharge, kind of in relation to the more recovery trajectory that you see in maybe sport concussion or adults, kind of putting it in context?
Mm-hmm. So I think what's so hard with thinking about like you said, like the sports concussion and more mild TBI is that it really, it almost is like two different things. And I think when I think of somebody who's coming in with concussion and my colleagues who work in concussion, again, I almost see that as a completely different animal than I do with moderate or severe TBI. And of course, there's going to be some similarities. They're all brain injuries. It's just two ends of the spectrum. But I see some pretty big differences there, and really what I was focusing on for this presentation, and I'm fine with sharing my slides or at least kind of taking out some of the copyrighted material and sharing the rest of them. But what you can see as you go through them in a little bit more detail is that the recovery from the more moderate to severe injuries, patients are going to go through phases when they're really disoriented, and this could last for days. And they might get really agitated, and that could last for days or even weeks in some cases. And so recovering from a concussion, you might have a very small snippet of that when someone's disoriented or confused, and then that kind of resolves. With more moderate to severe injuries, that often is lasting a much longer time. Does that answer the question?
Yes, I think that's very helpful. And I definitely agree with you. It's two totally different beasts. So I'm glad that we kind of put that into perspective, both at the beginning and at the end.
Perfect.
So thank you so much. This has been really wonderful. We really appreciate your time. And we'll post this on the website later this week.
Great. And I also will send you, there's a really great TED Talk. It's someone who's sustained a TBI as an adult, but I think he does such a nice job of explaining his injury. And so I can include that link as well, so people can watch that too.
Yeah, great. Thank you so much. We appreciate it.
Yeah, thank you.
All right. Thanks, everyone.